this talk that I'm going to offer to you all is related to the paper that we recently published, Shelley Cole, my colleagues from Mexico, and myself. And it talks about how the COVID-19 pandemic meets the diabetic pandemic. And we actually wrote this paper very early in April, where all the very few papers on diabetes as a risk for COVID-19 were just showing up, you know. And we decided that there was needed a paper that could include obesity, and not only obesity, but the pre-diabetic state, termed as insulin resistance, the metabolic syndrome, and the very important low-grade chronic systemic subclinical inflammation accompanying the pre-diabetic states, adipose tissue dysfunction, and sadly the forgotten postprandial glucose peaks that accompany the everyday whereabouts of a person after a meal. A little bit of an epidemiology that is written in the paper. Very early reports from China. Actually, this is the very early one that the reporting that 41 confirmed COVID-19 patients admitted in a Chinese hospital. 8 of them were diabetic, and 15% 6 died. However, to me, the important fact is the other 33 that were not type 2 diabetic. What happened to them? Were they pre-diabetic? Did they have insulin resistance? Did they have adipose tissue dysfunction? Who knows? So this is perhaps the spirit of the paper that we wrote with Shelley Cole and colleagues from Mexico, in order to highlight the importance of this gap between diabetes, obesity, the pre-diabetic state, and within obesity, the different categories of obesity by having healthy or unhealthy adipose tissue. Yang also reported that diabetes was found in 7 of 32 non-survivors from a group of 52 participants that arrived to the intensive care. Well, 25 non-survivors were non-diabetic. And finally, another study from Zhang reported that 16.2% with diabetes among 173 patients with severe disease out of 1,099 were confirmed with COVID-19 diabetics became, critically ill because of the diabetic states. But 145 out of 173 were not. And more recent papers like this meta-analysis have analyzed large amount of people. Let's say there is one meta-analysis from 46,248 COVID-infected patients, and they show that 80% had diabetes, a very large percentage of them. And this sort of correlates with the normal, or not normal, but the average diabetic prevalence in the United States, which is 10.5%. You know, this is perhaps the largest report from the Chinese Center for Disease Controls for COVID-19 patients and diabetes. They analyzed 72,314 cases, and they found out that there is a 3-fold higher mortality rate in the ones with diabetes versus non-diabetic people, 73 versus 2.3 respectively. This is a very important paper published by Bruce Bode, where he could gather 1,122 patients from 88 US hospitals, in which he could figure out that the cutoff point for glucose was very important to have the prognosis of the severity of the disease. And he found that among the patients that have diabetes, 386 patients with or without diabetes, but with high levels of hyperglycemia were not that affected compared to 184 patients of these 1,122. The importance of this paper is that it starts mentioning uncontrolled hyperglycemia. So both put together diabetic participants and participants who were not diabetic with uncontrolled hyperglycemia, which makes a big of a difference because it means that while they were developing the severity of the disease, they became with high levels of glucose that was uncontrolled. This is very important because another paper, recent paper from our Chinese colleagues, Liu Zhu et al., published in Cell Metabolism, also disclosed that the cutoff point of 180 milligrams per deciliter was a key factor between survival and death. So therefore, what this seems to implicate, which is nicely disclosed and written in our paper from Cole, myself, and colleagues, is that it seems like a combination of a damage directly to the beta cells from the coronavirus by binding its pancreatic ACE2 receptor may be affecting some insulin secretion. Also, the reports from Olga, our very own pathologist, while looking at the damage in the vasculature of the liver of the baboons and rhesus that she described recently in a seminar like this, in a webinar like this, and disclosing that in reality, this hyperglycemia in non-diabetics or the levels of glycemia while the disease is progressing in certain individuals may be a marker of the severity of the disease, not a consequence of the disease. And this is very important to consider. So therefore, it would be a very good practice in a hospital if that you get, unfortunately, with COVID-19, you are taken several blood glucose levels, perhaps through capillary measurements, and not the common measurement every second day fasting. So far, we know very well that people with risks for severe disease of COVID infections are the ones that are older, immunocompromised, or have significant underlying conditions, diabetes, obesity, heart failure, coronary heart disease, arrhythmia, and mainly any kind of limited lung function, such as asthma or acute or chronic pulmonary disease, among others. And they would most likely develop a bad outcome and multi-organ failure. But what sort of worried me and my colleagues is that when they refer to as these risk factors from the host, from the humans that are getting infected, they just mention in general diabetes and obesity. They don't go for the details of what happens to pre-diabetic individuals or the different kinds of obese people regarding to functional fat, because today obesity is being claimed by some authors, many authors, as an obsolete term that only refers to fat accumulation, and it doesn't consider at all the fat physiological function or the interaction of this fat with the immunological environment that we have. Indeed, in this report of obesity and COVID-19 from China, there were 380 patients, and they divided them as normal weight, underweight, overweight, and obese. And the conclusion reads that when they compared the obese versus the normal weight, there was an increased odds of developing severe COVID-19. This is expected. But if you see here, in the research and methods design, they compared the ones between 18 and 23.9 of BMI versus the ones 28 of above. So there is a gray zone of overweight people between 24 and 27 that might have had insulin resistance, might have had pre-diabetic states, might have had adipose tissue dysfunction, and mainly in between all these conditions, the deleterious low-grade chronic subclinical inflammation, which is key to exacerbate with the COVID-19 infection a cytokine storm and multi-organ failure. This is a study also described in our paper from Dr. Simonet from France. As you can see here, she could nicely and elegantly document that with a BMI above 35, these bars in red, you have a highest risk to get into mechanical ventilation and death. However, to me, when I see this, what calls my attention is the blue bar and the orange bar, where you have a BMI between 25 and 35. So if you put them together, you would have a larger amount of people that don't have so much BMI that also needed mechanical ventilation. So therefore, these people had to have some underlying mechanisms by which COVID-19 exacerbated their severity of the disease in the presence of not so high BMI. And this is another good point that we made in our paper. This is a recent paper, and it's linked to a declaration from the Center of Disease Control here in the USA, the CDC, in which they say that patients with overt diabetes and the metabolic syndrome might have up to 10 times greater risk of death when they contract COVID-19. Here, it's important to me, and I was jumping of happiness when they at last mentioned the metabolic syndrome that was not mentioned in any previous papers regarding the risk for a severely outcome of the COVID-19 infection. Well, what perhaps my colleagues from the emergency room, from the immunologic or infectious part of attending these patients and at the practice settings are not contemplating, because it's very difficult to be deciding what to do with a patient that arrives to the hospital with the signs and symptoms of COVID-19. I've been talking to so many friends down south the border that are actually risking their lives from the side of the treated professionals to be able to save these COVID-19s, and it's a little bit scary and it's a very stressful situation. But there is a difference between the metabolic syndrome and the insulin resistance that perhaps they don't have time to consider, and they should, because it may imply life and death, honestly. And this is what frustrates me and worries me a lot. When you talk about the metabolic syndrome, this is the clinical diagnosis of the pre-diabetic states. When you talk about the insulin resistance is just a physiological construct where a cluster of cardiovascular risk phenotypes are gathered with a common denominator called insulin resistance that leads to atherosclerosis, systemic inflammation, endothelial dysfunction, visceral obesity, type 2 diabetes, hypertension. But the clinical diagnosis is the metabolic syndrome. And the metabolic syndrome can be diagnosed very easily. A group of experts gathered together and had a position statement papers a lot of years ago, in which they say that if you have these 5 cardiovascular risk factors, waist circumference, elevated waist circumference, triglycerides, HDL-C, blood pressure, fasting glucose, and if you have 3 or more, then you have the metabolic syndrome. This is, to me, extremely cheesy and weak, because if you want to give problems to people talking about the metabolic syndrome and the clinical diagnosis, you just ask them, why is it that this expert panel just chose 3 out of 5? Why not 2 out of 5, the 5 or 1? And this means that the metabolic syndrome has been extremely controversial as a risk factor for cardiovascular disease, and not so much for the diabetic state because of the fasting glucose levels that is included in the criteria to diagnose. And this is important because from a clinical perspective, a medical student, a nutritional student, easily remembers the 3 out of 5 like criteria to diagnose. So there is strengths and weaknesses of the metabolic syndrome, but that's the difference with insulin resistance. And when we see all the cascade, the metabolic cascade from obesity, insulin resistance, the metabolic syndrome, and all the cluster of cardiovascular risk factors leading to endothelial dysfunction and cardiovascular disease, the only thing that comes to my mind is that we, people studying metabolism, have been highly arrogant in just crossing out or ignoring the inflammatory part of it. And this, what you see here, perhaps is the consequence of, as I speak, having deaths right now for COVID-19, which worries me and bothers me very, very much. Why? Because it's already been documented very elegantly that lean individuals can be metabolically healthy or unhealthy. Obese individuals can be metabolically healthy or unhealthy. And these 4 categories are highly ignored when somebody, unfortunately, with the COVID-19 signs and symptoms arrives to the hospital. And if we go back to adipose tissue dysfunction, which is the main objective, the main purpose of the GEM family study that we are doing in Mexico and Texas Biomed, is the same that the insulin resistance syndrome and the metabolic syndrome. The adipose tissue dysfunction is a physiologic construct that clusters a nice variety of inflammatory phenotypes: low adiponectin, high PI1, high fibrinogen, high levels of highly sensitive C-reactive protein, high levels of interleukin-6, high levels of TNF-alpha, and a hyperactivation of M1 macrophages and polarization of them, to lead to a clinical diagnosis, which could be chronic low-grade subclinical systemic inflammation. And this leads to insulin resistance. And this part of the inflammatory part of the metabolic aspects of the pre-diabetic states, of the diabetic states, is highly ignored in the clinical setting, with COVID-19 people actually arriving as I speak to the hospitals. Clearly bothering to my mind, honestly. Because what we endocrinologists, obesologists, people in metabolism highly oversaw for so many years is that indeed the metabolic syndrome is a pro-inflammatory state with a hallmark, the chronic low-grade subclinical systemic inflammation. All people with metabolic syndrome will have this subclinic systemic inflammation represented by this cluster of cytokines, pro-inflammatory cytokines circulating in their plasma. And now that we are analyzing things after a few months of this pandemic COVID-19, we can truly sort out that if you have a healthy or unhealthy expansion, if you are a lean, healthy or unhealthy, or obese, healthy or unhealthy, this expansion is a fight between hypoxia and angiogenesis that at the very early stages, perhaps when you have adipose tissue dysfunction, you get hit by COVID-19, and then that would exacerbate or make easier for the virus to replicate and trigger their inflammatory condition, which is 10,000 times faster, heavier, and worse. But if you are a little bit under this stage, the unresolved inflammation, let's say with a metabolic syndrome, or perhaps here in a pre-diabetic state, you are more affected if you got COVID-19 infections. And if you are here with an unhealthy expansion, already fibrosis, with an extracellular matrix remodeling already altered in your adipose tissue, which this implies a diabetic state, a frank diabetic state, well, you are at highest risk of COVID-19 for severe disease and multi-organ failure. This is why our paper highlights that at the foundation or the base of the triangle, we have this chronic low-grade subclinic inflammation that when meets the hyperinflammatory cytokine storm that comes because of the COVID-19, it leads to the hyperinflammatory state and multi-organ failure that you find in some people with diabetes or perhaps some other conditions very early to the frank diabetes status. And how do you measure adipose tissue dysfunction? Is another very important section that we discussed in our paper from Cole, myself, et al. There is an adiponectin leptin ratio. It's a very promising index that truly estimates adipose tissue dysfunction, you know? So in large databases where all people are included, healthy and unhealthy towards diabetes, they are analyzed and measured the adiponectin leptin circulating levels, and they do the ratios. The cutoff points are that if you have 1.0 or more, you can consider yourself healthy or normal. But if you are between 0.5 and 1 or less than 1.0, perhaps you have a moderate or increased risk for cardiovascular disease and diabetes. Here in this range, you could find people with insulin resistance, the metabolic syndrome, adipose tissue dysfunction, and whatever you want to call it, as we have seen and mentioned before. But when you have less than 0.5, that is extremely dangerous. So therefore, if we extrapolate this to the COVID-19 pandemic, you could easily see that these people with 0.5 or less may be the diabetic ones getting the severe cases of COVID-19, you know. So I can't help to think that if my good friend, Dr. Luigi Avedoni, would be in any hospital with his team and a Luminex, he would be able to measure this very easily. And then sorting out of patients would be much better towards who is really at risk or not of adipose tissue dysfunction and insulin resistance if they are not diabetics. Our study in Mexico, perhaps you have heard about it, perhaps not. We have a binational population study in which we study healthy, otherwise people, symptom-free people in 10 centers in Mexico, and we collect postprandial phenotypes and fasting phenotypes, including biopsies of muscle and fat. Our adiponectin leptin ratio in a subgroup of these individuals have given us that the cutoff point for us was 1.8, not 0.5 as in the other databases. Why? Because we study symptom-free, otherwise healthy individuals. However, what would the difference be in our database between the ones having a higher adipose tissue dysfunction versus a lower between these otherwise healthy individuals, meaning that people having 1.8 or more versus 1.8 or less. And what we found is that in the ones with a low adiponectin leptin ratio, 1.8 or low of this ratio, the TNF alpha was elevated from the ones of the high. Also, you find some sort of markers of inflammatory markers that are a little bit elevated within normal range, but elevated. Look, interleukin 6 is the same case, highly sensitive C-reactive protein, PI1, and our good interleukin 10, which is the anti-inflammatory one, goes down when you have low adiponectin leptin ratio within healthy, otherwise symptom-free individuals. This means that adipocyte dysfunction, adipose tissue dysfunction, can be detected in people very early without the need to be frank diabetic. And perhaps now, within the COVID-19 pandemic, this simple statement could be the difference between life and death. Because, I mean, why do you want to be exposed to COVID-19 if you have elevated pro-inflammatory markers? It's not wise, because you would exacerbate the inflammation coming with COVID-19. And this cannot be sadly detected in the clinical setting. It's sad, you know. So if you go to the postprandial data, the postprandial data is impressive. The HOMA insulin resistance index is an index of who's very much likely to become diabetics. It's very high in people with low adiponectin leptin ratio within the 1.8 cutoff point that we had in our symptom-free individuals, as well as the glucose, insulin, and GLP-1 curves that just talk that how these people are within their healthy status, let's call it like that, at the ones in red at highest risk to become diabetic. This, in this COVID-19 area, may be the gap of many people being sorted out in hospitals, sending back to home, that were not considered as high risk for infection, comparing the ones with the red line versus the blue one. I would be comfortable sending home a person that I know for sure has low levels of HOMA ER, low levels of a curve of GLP-1, but this is an ideal world, unfortunately. But this exists at least to consider. So if we go back to one of the figures of the paper, we can easily see that if we are 10.5% prevalent of diabetes, the prevalence of diabetes in the United States, in our 34.2 million Americans that we are, is 10.5%. And the rate of transmission, the R0 of SARS-CoV-2, is up to 3.5. It's easily that we could calculate that 4 individuals will infect very easily 14 individuals, and this one would go to 49. Mathematically, this is the precise rate of transmission, or infection. So out of these 49, 5, according to the prevalence of diabetics, will be infected with diabetes, frank diabetes. But what happened with the other 44? We don't know which ones are pre-diabetic, have insulin resistance, or adipose tissue dysfunction. And these 3 conditions are accompanied with low-grade subclinic inflammation as the hallmark. This is scary. And this is why perhaps we're seeing people that, are dying now, because this influences big time at large when you are infected with COVID-19, honestly. Therefore, the YEM study is studying what happens with the very early of this adipocyte tissue dysfunction, when there is a very early interaction between monocytes, macrophages, and the adipocyte. And then studies when there is a little bit more of this presence. So we're studying these 2 sides of this slide, the early stage of obesity, the very beginning of the late stage of obesity, where COVID-19 infects people nowadays walking, and then, I'm sorry, but they may be contributing these states of inflammation to the severity of the disease. And of course, when you have a metabolic dysfunction, where you are frank diabetes, hypertensive, heart disease, you know what happens already. Therefore, the insulin resistance, metabolic syndrome, adipose tissue dysfunction, the pro-inflammatory states should be considered as risk factors for people that are not frank diabetes for COVID-19 severity of the disease, as we see here, to lead to hyperinflammation, because this is the bed that exacerbates the inflammatory pathways of the COVID infection. So we're getting to the last part of the talk for the next 10 minutes or so. And we all know that diabetics, that we should call right now people with these glycemic states, that's the Endocrine Society of North America has put a position paper saying that from now on we should study the glucose levels of any individual termed as these glycemic states, in order to differentiate the frank diabetes with a very much risk at diabetes that offers another risk, such as the one of COVID-19 infection and severity of the disease. So there is a fact that if you have higher levels of glucose and you are or not diabetic, you are at higher risk of for susceptibility of a bacterial and a viral infection. The high levels of glucose or peaks of glucose, even postprandial ones, bother the work of the T lymphocyte response. They decrease neutrophil function, and they, honestly, the hyperglycemia per se, call it whatever you want to call it, postprandially, in fasting, frank diabetes, from the insulin resistance, from the metabolic syndrome, increased virulence of infectious microorganisms and leads to apoptosis of polymorphonucleases. So this is the contribution of glucose to the activity of our immune system and cytokine production out of them. I recently was invited by Winka Leclerc for the Texas Biomed Journal Club, Zoom one nowadays, and I presented this very provocative paper in which the title is very complex, in which Dr. Wang, a Chinese author, could elegantly present how viruses, RNA viruses, influenza A viruses truly hijack glucose and cellular metabolism for faster replication. And I'm not going to go into the details of the paper. If you want to have the details of the discussion for this paper, you feel free to access our Dropbox from the Texas Biomed Journal Club, where Dr. Winka Leclerc kind of uploaded this discussion that we have a few days ago. But the important fact to mention here is that virus control of cell metabolism is there for replication and evasion of the host immune responses. You know, viruses clearly rely on the host cell machinery to propagate, you know, and it's not surprising that these viral infections trigger some metabolic reprogramming, so that when they invade the host, there is an easier way for them to virus replication and assembly. And actually, this is described as the virus is hijacking the host's cellular metabolism. And just a quick reminder that glucose, when it's uptaken by muscle, liver, any cell, it usually goes in the cytoplasm towards a glycolytic pathway called PPP, the phosphate pentose pathway that leads to pyruvate. Once pyruvate is enough, because of the glucose uptake, the pyruvate normally gets into the mitochondria, to the Krebs cycle, for oxidate phosphorylation through the respiratory chain, leading to ATP formation. So this is the way we normal eukaryotic cells have cellular respiration and use our substrates, metabolic substrates inside the cell. But the viruses start switching this metabolism towards some other pathways in order to be able to hijack nucleotides for replication, fatty acids, and amino acids to make their core to be more potent and less prone to be destroyed by the immune system. That's the danger. In their paper, Wang et al. Described that influenza A virus enhance a specific pathway for utilization of glucose, the hexosamine biosynthetic pathway. The virus enhanced this pathway to utilize glucose in excess, leading to the final enzyme product of this pathway, which is OGT. It's an enzyme that works with O-GlNAc, which is the product, which would influence and exacerbate the expression of another protein, an interferon regulatory factor 5. They elegantly showed in their paper through infection of influenza A virus in vitro and in vivo in mice and in humans, how this pathway triggered a cytokine storm that damaged the lung through interferon increase and increase of the expression of the pro-inflammatory genes in the cells through the hexosamine biosynthetic pathway. Here is just to remind you that the hexosamine biosynthetic pathway utilizes up to 5% of the normal glucose in eukaryotic cells. The final products are OGT and the UPD O-GlNAc, and this OGT, through the glycation glycination that it produces, it influences the most powerful pro-inflammatory cascades, which is the IKK and FK beta, in order to produce deleterious cytokines. And in reality, the viruses, by hijacking this hexosamine pathway, they have access to glutamine, to fatty acids, to nucleotides and amino acids in order to replicate faster. They elegantly showed that when you in vitro administered increased amounts of O-GlNAc, viral replications, as you see in the black bars, go higher. They did RT-PCR in the in vitro studies in PBMC cells and alveolar type 2 cells. So this effect of O-GlNAc on viral replication, that is the reflection of the hexosamine and pathway and glucose utilization, led to a higher titer of these viruses and different mRNAs, the messenger, complementary, and viral, as you can see here. When they maintain a steady amount of O-GlNAc in the median, they could find increased titers of the virus up as short as 12 hours after, then 24, and 2 days later, the viral replication was higher with the O-GlNAc medium that they have. I mean, as long as they have O-GlNAc, they were able to replicate and increase their replication. This is the in vivo work they did, Dr. Wang. Beautiful paper, honestly, in which they administered O-GlNAc 50 milligrams per kilo per day intraperitoneally, injections for a week versus placebo. And then they found, versus controls with placebo, and then they found that after infecting the animals with influenza A virus, you follow the controls in black versus the Oglinac administration with the infection, you see how the weight of the mice were never altered in the controls, but it was a tremendous weight loss in the orange line compared to the red line, which is only AIV infection, or the blue line, which is just Glinac administration. So the survival rate was also the same pattern, compare the control versus the Oglinac versus the influenza A virus, and then they could measure the amounts of cytokines, and you can see in orange bars how the pro-inflammatory cytokines were more elevated when Oglinac interacted with influenza A virus, you know, and then they got, you can see here in K, how they got higher titers of the virus in the Oglinac influenza A virus treated parts, you know. So they induced AIV replication in mice, and they could show that Oglinac is key to interact with this influenza A virus to produce a stronger cytokine production. They showed the same here when they overexpress OGT, the viral replication was higher. And this perhaps is my favorite slide from the paper, in which they collected fresh blood from healthy individuals and from patients diagnosed with influenza A virus in a year. So as you can see in here, like the persons infected with influenza A virus had higher blood glucose levels. The Western blot analysis showed a stronger Oglinac expression in the AIV infected patients. The interleukin 6 was higher. The correlation between blood glucose and interleukin 6 was very direct, very nice correlation, and they could find that Oglinac really correlated versus healthy individuals in AIV infected patients, the influenza virus, regarding the expression of the interferon regulatory factor 5. And I have already described the cartoon at the bottom, where influenza truly leads to a cascade of the hexosamine pathway towards IRF5, leading to a cytokine storm. In reality, I'm practically finishing around here. Glycosylation is being termed as the orchestrator of immunity. And there are recent papers like this one, very nice, Chang et al., where it shows that oglycylation is important in neutrophil action, in macrophage action, in thymus cells action, in spleen cells action, in T cells action. So the hexosamine pathway is important in the function of the immune system in normal conditions, you know. And this is a very provocative paper that I was just reading as of yesterday, in which they show that Oglinac transferase inhibits visceral fat lipolysis and promotes diet-induced obesity, meaning that by blocking Oglinac, you may be able to have a potential target for obesity in the treatment of obesity, which is fascinating for me. Here is just to reinforce that the G's that you see here are the work of the OGT on the IKK cascade coming towards TNF alpha and the NF kappa beta targets to create overexpression of pro-inflammatory genes when COVID-19 is present, and how OGT from the hexosamine pathway, implying that the virus is perhaps overutilizing glucose and hijacking a pathway that should not be overworking. It's leading to interferon-like deleterious activities. Here is a very nice paper as well that I just found a few days ago, that in reality this ubiquitination of IRF5 influences polarized macrophages of the MI kind in order to regulate glucose intolerance in obesity in mice. So, and another provocative paper that I found is that the importance of this interferon regulatory factor 5 expression in diabetic obese patients, that when you compare the signatures of the metabolic inflammation they have between diabetes or not, you see that persons with higher expression have a stronger signature of inflammatory markers. And finally, we're at about time to finish, the forgotten postprandial peaks of glucose. It is a fact that postprandial hyperglycemia is a categorical etiological factor of vascular failure. No one seems to measure it. They all are fixed with a fasting biochemistry panels that we have for our patients in the practice setting, where what the only thing that we are doing is to start interrogating a quiescent cell after 12 or 8 hours of fasting. If we are talking about metabolism and its interaction with the immune system, we need to challenge how it works. And it is clear that after a breakfast, lunch, and dinner, whether you are diabetic or not, some people that are not diabetic, but they are at risk of diabetes with insulin resistance or adipose tissue dysfunction, are going to have oxidative stress because of the low-grade chronic subclinic inflammation again and again to lead to endothelial dysfunction. So these postprandial peaks are very important, perhaps now in the era of the COVID-19 pandemic. And we mentioned that in the paper, in which we say that perhaps people that are not aware, they feel they are okay, they just hear that if you are diabetic, you are at high risk, and they go out, they are a little bit chubby, they are a little bit overweight, you know, and they just ate a lot, and they go to shopping, and they face the virus. To what extent, because we don't know if this is true, at least it's true in the influenza A viruses, until what extent this would be exacerbating that you will have a worse infection if you catch a COVID-19 infection. This is a valid question. And why this is a valid question, I'm really happy and pleased to be finalizing more or less my talk with this paper from Petrilli, in which here in the United States, in New York City, they saw in the practice setting 4,103 participants, you know, from the health system in New York City, just as early as May, June and May, you know, and then they only left in the hospital 1,999. And then they said that their main criteria for them to be hospitalized were 65 years old or more, or a BMI be above 40 if they had heart failure. So the ones with mild symptoms, they just send them back to home. So 2,104 participants, patients with COVID-19 symptoms were sent back to home. So, well, I mean, when they measured the CRP, C-reactive protein of the ones with 65 years old or more, or BMI above 40, I mean, I had no doubt that they would have had high levels of C-reactive protein, you know? But what happened to these people? Were they affected by postprandial hyperglycemia? Were they affected with insulin resistance? Did they come back the next day worse from the symptoms? We'll never know. No wonder we are reading what happened in New York City. And here is my last slide. SARS-CoV-2 may enter, enhance the exosomal pathway, and perhaps as influenza A virus interacts with the metabolic cellular pathways of the cell, hijacking it, leading to, as we talked endlessly, with the OGT overexpression and influencing interferon-like mechanisms that would create massive inflammatory gene expression or a cytokine storm that would truly hurt the persons. I'm really pleased and happy. I'm just about to finish now for questions and answers that our senior leadership, Joanne Turner, Dr. Larry, Deepak, all the ones that were leading this study, we have already created a model in rhesus and baboons of COVID-19 infection. This is extremely important, and we need, if we are from the Texas Biobank, we have to be proud of what is being achieved, honestly. And I've been talking mainly with Deepak Kausal, with Joanne Turner, Shelley Cole, Pat Frost, Chris Chen. We are establishing, I talked deeply with Deepak, and then we may be able to establish a task force in order to measure the impact of glucose and cellular metabolism in the pathogenicity of SARS-CoV-2 infected baboons with dysglycemia. What are the implications for adverse clinical outcomes and viral replication? This is an extremely important question nowadays that we will be doing soon, and I hope that my next participation will present solid data, not expert opinions from a paper. And I thank you for your time, and I'm ready for questions and answers.